it is really nice to, it's really nice to be recognized for things that you value in yourself. And that felt like just exactly the right presentation. Oh, should I say got it?
Yeah.
Oh, I can't see. Oh, I
On
see.
the other mouse, the mouse for the.
You guys are challenging my. Oh, that mouse. I see. Okay, great. It is always so wonderful to come back here to Hopkins, to Baltimore, and see people that I have known and loved for a very, very long time. It feels like I'm coming home in many ways. So today my talk is titled Beneath the Sword of Damocles, Moral Obligations of Physicians in a Post-Dobbs Landscape. So this is the first time actually I've given this talk. It's the product of a paper that Ruth and I conceived a couple of years ago and wrote together with Michelle Mello. It's coming out someday in the Hastings Center report, but in lieu of that happening yet, I'm going to share with you what we came up with. Forgive me that this is the first time I've presented this, so it may not be as polished as I would love it to be someday. So in 2012, the tragic death of a young woman from a miscarriage galvanized the Irish public into protests, eventually leading to the repeal of a 1983 law, which had effectively banned all abortions in Ireland. You can see her face on this sign. Her name was Savita Halappanavar. At 17 weeks gestation, she presented to the hospital with ruptured membranes and signs consistent with inevitable miscarriage. Doctors waited days until the fetal heartbeat had stopped to end her pregnancy. It was a delay that they thought that the law required, and it was a delay that cost Savita Halappanavar her life. She developed sepsis and died. So in the inquiry that followed, Peter Boylan of the Irish Institute of Obstetricians and Gynecologists noted, the current situation is like a sword of Damocles hanging over us. If we do something with good intention, but it turns out to be illegal, the consequences are extremely serious for medical practitioners. Indeed, Boylan was referring to an ancient moral parable ascribed first to Cicero, in which King Dionysus II offers to switch places with a court flatterer named Damocles. When Damocles takes the throne, he notices a sword above his head dangling by a single horsehair. The story has been evoked across the Western canon, including in Geoffrey Chaucer's Canterbury Tales, which I have placed here, and which I couldn't help because the undergraduate English major in me likes to remind herself who she is sometimes. So, though specifically an allegory for the imminent and ever-present peril faced by those in positions of power, it is often used to denote a sense of foreboding engendered by a precarious situation, especially one in which the onset of tragedy is restrained only by a delicate trigger or chance. Here are the hazards of pregnancy up against the capricious and cruel laws that restrict abortion. So it is a situation we face today following the 2022 Supreme Court decision in Dobbs versus Jackson Women's Health Clinic, which effectively rescinded protections established 50 years ago by Roe versus Wade. You can hear echoes of Boylan in this quote from a recent publication by my colleagues in JAMA Open Network. They interviewed a number of physicians who were trying to navigate the new restrictions on abortion. One of them said, "I know what the right thing to do is for my patients, but I am carrying this legal worry and worried about what could happen to my family at the same time, and that's a terrible thing to feel." How, morally speaking, should doctors respond? In our paper, we address a pair of questions that we think might help. One, do the moral obligations that support providing clinically indicated care that is illegal because of abortion restrictions outweigh the obligation to obey the law? Is breaking the law in these cases morally permissible? And two, are clinicians morally obligated to provide illegal abortion care where the life or health of the pregnant person hangs in the balance? So, a quick outline for my talk. As Ruth always talked about, we should provide a roadmap for our ever the mentee I am. So first I'll talk quickly about the post-Dobbs landscape, offer a typology of paradigmatic clinical cases that our framework applies to, review the state laws that restrict abortion in these paradigmatic cases, offer why breaking the law in such cases is morally permissible, when breaking the law is morally obligatory, and then turn to obligations of institutions. So the post-Dobbs landscape. In rescinding Roe's protections, the Supreme Court returned governance of abortion to the states. As it currently stands, this is January from the New York Times, which I check too often, 21 states ban or restrict abortion earlier than Roe. Bans are blocked in 3 additional states, and abortion is legal in the remaining states, some with additional protections now. It is, of course, the states where abortion is banned that these questions will come up with greatest urgency. Notice here that restrictions are concentrated in adjacent states, primarily in the South, such that access to jurisdictions where abortion is protected might be particularly difficult for some individuals. Okay, so in our paper, we focus on a subset of cases in which we believe highlight dramatically the moral tensions that physicians face in restrictive states. These include cases where pregnancy poses a serious threat to the life of the pregnant person. This we'll call scenario 1. These are cases like that of Savita Halappanavar, preterm, pre-viable rupture of membranes. These are also cases such as when pregnant people with primary pulmonary hypertension, when people with primary pulmonary hypertension become pregnant and face, at the time of delivery, up to a 50% chance of death. But that death is, temporally distant from the moment of pregnancy diagnosis. And that becomes relevant in a bit. You'll see why. Pregnancy, a second kind of case is where pregnancy poses a threat to the physical health of the pregnant person, scenario 2. So diabetes, epilepsy are chronic conditions that can become much worse during pregnancy. Diabetes can lead to blindness. Some women with epilepsy face intractable seizures and the prospect of permanent neurological damage from pregnancy. Women can become with cancer or can get cancer during pregnancy and may need to delay treatment, putting their own health in harm's way. There are also cases where pregnancy poses a serious threat to the mental health of the pregnant person. These cases are broad, but we consider in particular cases of rape and where pregnant people are forced to carry pregnancies affected by lethal fetal anomalies. And fourth are cases where the future fertility of the pregnant person, where pregnancy poses a serious threat to the future fertility of the pregnant person. It turns out, as we were thinking about these cases, pretty much all of those that we could think of also posed a serious threat to the health or the life of the pregnant person. So we kind of lump those together. One example would be cesarean scar ectopics, where the pregnancy implants in the cesarean scar, which is both a threat to future fertility, but it's also a threat to life. So when does the law allow abortion in these cases? So it turns out when we first started writing our paper, only all but 3 states offered an exception for the life of the pregnant person. Now all states offer that exception. All except 5 states make exception for pregnancies that threaten the physical health of the pregnant person. And for the time being, I'll just say it depends when it comes to the mental health. You know, at first glance, this looks horrible, but not as horrible as you might think. But a deeper dive reveals that a situation that is far more complex and I will offer dire. So let's take these scenarios one at a time. So scenario 1, the life of the pregnant person. As I said before, all states have exceptions for the life of the pregnant person, and the language differs across the states, but it's something like abortion is banned except in cases where it is needed to save the life of the mother in a medical emergency. These exceptions, however, are limited in at least 2 important ways. The first is ambiguity. What's the definition of life-threatening? What's a medical emergency? These definitions are vague and interpreted differently by different legal councils, different legislatures. Also, pressingly, is the question of urgency. So in most interpretations, there is the requirement for death to be imminent, which means that it precludes abortion in cases where death is likely, as in the 50% chance of death in primary pulmonary hypertension, but in the future, right? So we want to terminate the pregnancies early so you don't get to term and face that kind of mortal danger. It also requires doctors to delay care until a patient becomes severely ill. So again, my colleagues interviewed doctors, and I think this quote really speaks to that latter concern. The way our legal teams interpreted it, until they became septic or started hemorrhaging, we couldn't proceed. It puts women in a very challenging, risky position. Is a 5% risk of death enough? Does it take 20%? Does it take 50%? What is enough legally? And the legal people seem to have a different definition that also just feels horrible. To say, until you're at a greater than likely chance of dying, you can't make a decision. Okay, so scenario 2. So lest you feel reassured, don't. Scenario 2, the health of the pregnant person. 5 states offer no exception for the health of the pregnant person. So pregnant persons with chronic and severely health-threatening conditions like diabetes, epilepsy, and cancer must continue pregnancy, even if that means facing the prospect of blindness, neurological damage, progressing cancer. Other states offer some exception for the health of the pregnant person, and the language varies again, but it tends to be in situations where pregnancy poses substantial and irreversible impairment or imminent peril of a major bodily function. The exceptions, again, are limited by ambiguity and the requirement for urgency. The problem of ambiguity is this, in fact, the central concern in a prominent case, Zarowski versus State of Texas. It was originally filed on behalf of 5 women and 2 doctors, one of whom was a residency mate of mine, one of the doctors. 22 women now are a part of the lawsuit. And it argued that the state's abortion bans threaten their lives, health, and fertility, despite the fact that the state has life and health exceptions. The case was most recently argued before the Texas Supreme Court in November. I encourage you to read about these cases on the Center for Reproductive Rights website, and the case filed itself has some really harrowing testimony. I'll share one piece of it with you. So they recount the case of a woman who at 15 weeks was diagnosed with something called a partial molar pregnancy. These pregnancies do not result in a viable fetus due to genetic problems, and also can lead to gestational trophoblastic disease that cause the pregnant person to develop cancer. In addition to that, they experience thyroid problems, dangerously high blood pressure, and agonizing, often, ovarian cysts. Yet again, because her fetus had cardiac activity in partial molar pregnancies, they can. Multiple ethics committees refused to provide an abortion, and she had to wait several days before she received one. So that's in a state with a health exception. Okay. Scenario 3, mental health of the pregnant person. So several states expressly exclude mental health, including threats of self-harm, from life or health exceptions for abortion bans. So what that means is mental health doesn't count as life or health threatening, even though, recent article came out in JAMA that showed that mental health is the leading cause of maternal mortality in this country. So, for example, in West Virginia, exceptions do not apply where the woman will engage in conduct in which she intends to result in her death, or in substantial and irreversible physical impairment of a major bodily function. Florida, other than a psychological condition. In addition, however, 5 states do have exceptions for rape, but often require proof or other reporting in order to obtain an abortion for rape. 8 states have exceptions for lethal fetal anomalies, which I connected to mental health previously, but there is confusion about what conditions qualify. I wanted to, again, just share a story because I think stories speak most directly to the challenges at hand. And that's the story of Deborah Dorbert. Her story was portrayed really beautifully in a Washington Post series, and it's also been reported elsewhere. So Deborah Dorbert was pregnant with her second baby. She had a 4-year-old, and her fetus was diagnosed with something called Potter syndrome, which is essentially the congenital absence of kidneys. Without kidneys, you don't make amniotic fluid, and so the lungs don't develop. So this is considered by most, if not all, a lethal fetal anomaly, because even as these babies develop, they cannot breathe when they're born. State law in Florida had an exception at the time for fatal fetal anomalies, but the doctors refused to terminate her pregnancy due to the presence of a fetal heart rate. So she was required to carry this pregnancy to term. She, as you can see from this picture, looked gloriously pregnant. She had a 4-year-old who she had to sort of manage their expectations about their sibling, and who she couldn't bear to tell was going to die when was born, answer questions in the elevator about when she was due. She noted, "I just got very depressed and anxiety was horrible. I just didn't want to get out of bed most days. I would just break down crying." She was induced at 37 weeks gestation, and she reflected, "When he came out, you could hear him gasping for air. He was really just trying to breathe. He didn't cry when he was born, and he didn't open his eyes at all, but I mean, he struggled." The grandfather of the baby said, "To me, it's just pure torture. The law has created torture." So I'm going to speak very briefly about EMTALA, which I am not a lawyer, so I can't speak that directly to it. Michelle would do a much better job than I would, but some people have looked to the Emergency Medical Treatment and Labor Act as a means to mitigate the legal restrictions. It requires that hospitals with an emergency department that participate in Medicare provide stabilizing treatment to patients with an emergency medical condition. It's limited since it just applies to people who present to the ER with a life-limiting condition. If you develop it later on, it's not clear that it applies. And it's contested. The Supreme Court of the United States will hear arguments about the law in Idaho in 2024. So how should doctors respond to this very, very difficult situation? So I'm going to remind you of the sort of two questions that we asked in our paper. Do the moral obligations that support providing clinically indicated care that is illegal because of abortion restrictions outweigh the obligation to obey the law? Is breaking the law in these cases morally permissible? And we'll get to the second question later. So why breaking the, so our answer is yes, it's morally permissible. And we offer a total of 4 arguments for why it is. The first, we do not fully defend, but one of the arguments that is presented most commonly around why breaking the law is morally permissible is that the law is unjust and there is no obligation to obey an unjust law. Most people think what's happening right now is unjust. Starting from the UN High Commissioner on Human Rights to the US Attorney General, to ACOG, the Society for Maternal Fetal Medicine, most medical professional societies, and, you know, certainly the doctors that were interviewed by Sabbath et al. But there's 3 additional reasons why breaking the law is morally permissible, right? So we have a moral obligation to obey the law, but there are reasons by which breaking it is morally permissible. And these include to protect conscience, to abide by professional obligations, and as a means to change an unjust law through civil disobedience. So I'll quickly go through these one at a time. So conscience is the first one. So conscience has been defined, I think, eloquently by Jim Childress, as the private, constant, ethically attuned part of the human character. So it is easy these days to imagine that to practice medicine in accordance with abortion bans may present a conflict of conscience. Allowing Deborah Dorbert to have to carry her pregnancy through to term, allowing a person to get sick before you intervene, getting somebody close to the brink of death, all would present conflicts of conscience for many obstetrician gynecologists, ER doctors, family medicine doctors that I know. ACOG agrees and issued a statement, a joint call to action last year, and called Post-Dobbs restrictions and ethical infringement in clear conflict with the calling of obstetricians and gynecologists, which forces members of our specialty to carry a burden of moral injury and distress. So when we think about conscientious refusals, they have actually received very strong support, including federal protections ever since Roe v. Wade through the Church Amendment, but ongoing. We could talk all day about protections for conscience. They are grounded in the right, as Jim has offered, to moral integrity, the soundness, reliability, and wholeness and integration of a physician's moral or a person's moral character. So the thing about conscientious refusal is that it has tended in the past to center around the refusal to provide care. And I know this very well because when I was the chair of ACOG's ethics committee, we were trying to respond to claims of conscience that led to refusals of reproductive health care ranging from provision of contraception to provision of fertility services to provision of abortion by individuals who felt that providing those standard medical treatments would be in conflict with their conscience. So ACOG issued an opinion talking about the limits of conscientious refusal in reproductive medicine. And one of my proudest but most harrowing moments was when ACOG and I received a letter from 12 senators telling us that this committee opinion needed to be rescinded. It is, by the way, still in place, reaffirmed as of 2019. So, but the point here is that, as my colleague Lisa Harris and others have noted, the provision of these services, certainly of abortion, of contraception, of things that support women in their reproductive lives, are also conscientious acts, right? So the idea is that one might also conscientiously refuse to follow the law, right? And what Ruth and Michelle and I argued in our paper was that arguably the position in which one would refuse to obey the law is a stronger one than the position that has been defended by those that would refuse to provide care on at least 3 counts. So refusals to provide care oppose patient autonomy and interests, right? Somebody is coming and asking for abortion or needing an abortion, and those conscientious refusals are opposed to that. Refusals to follow the law, in fact, support patient autonomy and interests. Refusals to provide care deviate from standard practice, where refusals to follow post-Dobbs laws align with standard practice. And third, perhaps most tellingly, is that refusals to provide care have negative consequences for patients, whereas refusals to follow the law, primarily the negative consequences fall on the doctors, the brave doctors who decide to refuse. Okay, so conscientious refusal. Second, professional obligations. Physicians, as we all know, I don't need to tell the folks in this room, have a fiduciary duty to prioritize patients' best interests. State bans often restrict standard care, even care normally provided by those who oppose abortion, right? Those who provide abortion will still take care of people with, ectopic pregnancies. They will still terminate pregnancies with pre-viable rupture of membranes. This is part of the bread and butter of OBGYN. So following the law may violate a duty of non-maleficence. So, but what we know is that deviations from standard care are far from rare anecdotes. A group out of San Francisco who was working with the Texas Policy Evaluation Project published a report last year that cataloged more than 50 such deviations from standard care for women who had pre-viability complications like PROM, hemorrhage, and hypertension, right? So somebody who has severe preeclampsia needs an induction, and those are not done. Ectopic pregnancies, read the paper this week, there's been another case of a ectopic pregnancy that was not treated in Texas. Underlying conditions that make pregnancy dangerous, severe fetal anomalies like Deborah Dorbert's, there are many others, anencephaly, et cetera. Early miscarriage, there have also been extreme delays in abortion care and delays in medical care unrelated to abortion. Okay, third, so we've got conscience, we've got professional obligations, civil disobedience. So a third justification for breaking the law would be as a means to change it through professional civil disobedience. So civil disobedience has been defined, and quite eloquently, I would add, by Jim Childress as a public, nonviolent, and conscientious breach of law undertaken with the aim of bringing about change in laws or government policies. It's certainly not an obligation, but courageous and worthy of praise. So in writing this paper, I actually learned a lot about civil disobedience. So I just wanted to share with you that it is, different in important ways from conscientious objection or conscientious refusal. So civil disobedience is a public-facing act, whereas conscientious refusals tend to be private acts. Civil disobedience is supposed to be communicative, a form of speech. So I am performing this abortion and I want you all to know, versus I'm performing this abortion quietly in this room and we're going to get it taken care of. So civil disobedience is communicative, conscientious refusal is personal and protects a person's moral integrity. Civil disobedience accepts or invites legal consequences. So going to jail because you've done something is part of the project of civil disobedience. Whereas conscientious refusals aim to have protections for the expression of conscience, right? That's why we have all of these protections, these legal protections that have been advocated for. So again, just to summarize, there are at least 4 reasons that breaking the law is morally permissible, that is unjust as a means to protect moral integrity via conscientious refusal, because it upholds professional responsibility, and it's a means to change the law through civil disobedience. Okay. Yep. So the next kind of obvious question is, are clinicians morally obligated to provide a legal abortion care where the life or health of the pregnant person hangs in the balance? Individuals might answer this in different ways, but are they generally morally obligated to provide this care? Martin Luther King, in his famous letter from the Birmingham jail, said that one not only has a legal but moral responsibility to obey just laws. Conversely, one has a moral responsibility to disobey unjust laws. So he might say yes. So what Ruth, Michelle, and I settled on was a circumscribed duty to treat. So doctors in their public testimonies and expressions have noted the serious consequences of disobeying post-Dobbs laws. These have included civil and criminal penalties up to life in prison, also loss of a job, licensure, and harm to their families. It's notable that the 2 individuals, the 2 doctors that are signatories to the lawsuit in Texas, one is in private practice all by herself and the other is retired. So in a 1991 paper on the duty to treat in the context of HIV, Norm Daniels argued that doctors have a limited duty to treat where the risks of providing care exceed what might reasonably have been anticipated when a person entered the field of medicine. So the idea is that when risks exceed some standard level, as they most certainly have in many states, none of it's expected, although we should have, that's how we would say it in North Carolina, sorry. Provision of care may well be beyond the call of duty, with 2 exceptions. So the first is that the law does not supersede a physician's duty not to abandon their patient. So that when a threat is urgent but not time sensitive, we believe that physicians still have a moral obligation to refer to a doctor who is willing to risk legal sanction or practices in a jurisdiction where abortion for that indication is legal. Second, if a physician has the means to prevent the death or life-threatening harm to a patient, their duty to provide care remains. When such a threat is urgent and time-sensitive, a woman is hemorrhaging, for example, the doctor has a moral obligation to intervene to save her life, even if it seems to break the law. Needless to say, physicians should not be left out to dry. Institutions have moral obligations as well, including refraining from self-protective action that increases physicians' burdens and providing a basic suite of supports for physicians who are at risk. So we talk more about this in our paper, but I'll quickly review it. So first, refraining from protective action. Harmful behaviors that we have seen far and wide, unfortunately, include poor communication, interpretations of the law that prioritize institutional risk mitigation over patient health and physician integrity, requiring legal counsel or, quote, ethics committees to approve physicians' decisions about provision of abortion care. I would call them unethics committees, but that is what they have been called in some cases, and silence on it. In the presence of such self-protective action, there is a worry, and I think Michelle had articulated it nicely in her 2022 piece, that a new and pernicious form of defensive medicine will emerge, and I think we are already seeing that happen. So we also argue that institutions have an obligation to provide a basic suite of supports. What might this constitute? We believe that institutions should stand behind doctors who provide illegal but medically necessary abortion care by speaking publicly in defense of physicians. So you might imagine if a physician was performing a procedure as an act of civil disobedience, then the institution would stand behind that doctor and speak on their behalf, paying legal defense, resisting investigative demands that could lead to prosecution, providing assurance against employment consequences, threats of which have been reported widely, psychological support services, security measures for physicians, and refusing professional sanction on behalf of licensing boards and professional societies and again, these are the things that physicians fear and have led to this pernicious defensive medicine. So I mentioned before the case of Zurawski versus the state of Texas, and this is a photo of the brave and articulate Amanda Zurawski. Like Savita Halappanavar, her membranes ruptured at a time remote from term, 18 weeks here. Doctors delayed her termination due to the presence of a fetal heartbeat. She developed sepsis, was transferred to the intensive care unit, and an induction of labor was performed emergently. She fought for her life, and she, unlike Savita Halappanavar, lived. Now she's fighting the fight for other women and has become one of way too many faces of post-Dobbs America. So in conclusion, state laws have created barriers to life-saving and life-preserving care for pregnant people. Breaking such laws may be morally permissible on the basis of conscience, professional obligations, and civil disobedience. Breaking the law is morally required where there is a serious threat to life, either by referral in non-time sensitive situations or provision of care where the situation is time sensitive. And institutions have an affirmative duty to support physicians and other providers of reproductive health care. So I'll end with this beautiful but sort of harrowing picture from the New Yorker of sort of our post-Dobbs specter. And I think, we are doing our best to make sure that that is not how the experience of pregnancy is perceived going forward. Thank you.
Hi, I'm actually one of the talking here at Berman, and thank you for a fabulous and enraging talk. As I'm a genetic counselor by background training, I don't practice this, so I always think it's a struggle that we have as genetic counselors in this space for some the referrals, and I know there's some changing in counseling practices where their own providers in some states with licensures and others. I'm just wondering, one, have you had any discussions about the roles of supporting the genetic counselors that are playing in this space? They're not actually performing abortions, but they're referring patients to care providers and are also at legal risk.
Yeah.
And my second question is, in your model system of the three ways, whether they're threat to life, threat to health, does the model encompass, those aren't necessarily mutually exclusive categories? So I was wondering if you have any thought in the paper about the additive effects, like someone could be raped and now have a pregnancy that's putting them at risk, or you could have a fetal anomaly that puts the mother self-lifts. There's hydrocephalus or things like that. I'm just wondering if your model, if you have an additive effect of those options or looked at them.
So both excellent questions. So I think we take a bit of time in our paper to talk about healthcare providers other than physicians. But, I don't think we specifically mention genetic counselors, and it seems to me to be an incredibly important set of considerations. And, again, they may be different. There is certainly, an ethic that genetic counselors abide by that is different, in some ways more specific than what doctors do, but certainly of profound relevance to this situation. So, it's definitely an area to think about. I haven't really read anything about genetic counselors either. So
there's some debate in the focus of the organization.
Oh, really?
Well, in terms of how they spread their financial ability to advocate, and they're advocating for more licensure and reimbursement to be their own providers, and it doesn't leave as much bandwidth to maybe reproductive choice advocates. So that's just the scuttlebutt I have reading on the periphery. So
Wow.
I just think it's an interesting. I know authors that are in a really tough space because we usually are the liaison from the typical OBGYN who refers a patient, and then we find anomalies and then have to sort of help them get to the next level of care and find an abortion provider, which has long been a challenge in this space, period.
Yes. And even more so. Yeah. Well, thanks for raising that. A lot of food for thought. In terms of additive, I think you're absolutely right. I mean, there are ways in which all of these pieces of our framework, interface with each other. Indeed, like if you have a life and a health risk, a life and a health exception, but in order to abide by the life exception, you make somebody permanently harmed. I don't think that's been adequately sort of addressed by the legal teams that are trying to interpret these laws, and I think are doing a pretty terrible job. So I think it's a good question, and they do interface with each other, but I think in terms of additive, I think that each one is sufficient on its own. So yeah.
Another question, please.
Hi, I'm Chuck Streeter. Second release, thanks for the ratio. So I was, I'm convinced by the conclusion sort of multiple times over, but I was listening to you, I got worried about the conscientious objection point. And so I wanted to ask you a little bit about that one, because you all thought about it longer than I have. And so there are two features of the conscience argument that sort of stuck out such that I'm not sure I want that principle to be operative in other spaces. And so one of them is that, your refusal to follow the law is different from refusal to act, because refusal to follow the law can be an action rather than an inaction. And so when the doctor doesn't fill a birth control prescription, part of the conversation is so long as they have access to somebody else who will do the job of that care provider. But taking action can be irreversible in a way that 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 isn't. So refusal to follow the law can be a positive action rather than a refusal to take action. That's one part. And the other part is, it's the only piece of the only argument of the four that's subjective instead of objective. I'm not sure I want everybody's conscience operative in deciding whether to follow laws. And so I really want your conscience to be operative. But I meet a lot of doctors, and I'm not sure I want all of their conscience to be operative. And so, all the others, like unjust laws, that's an objective measure. So yes, you have permission to disobey unjust laws, and so civil disobedience can be operative, right? But conscience isn't like that. Some people have really bad consciences. So those were like the immediate worries that came to mind, but I wondered if you all had talked about those points and could allay my fears.
Yeah, well, thank you. I mean, I've thought about conscience more than I, want to admit. And I will tell you that my first foray with conscience was one of profound skepticism, right? Because conscience was being deployed to refuse patients standard healthcare and things that they wanted, that they needed. And so the ACOG piece really articulates a framework for understanding what conscience is and the ways in which it, that it should be respected, but you need a robust understanding of what it is. So just because my conscience leads me to have certain beliefs about science, right, doesn't mean that I can deploy my conscience in that way, right? So I think that, at the time, there were a lot of people that said, I'm not providing emergency contraception because it's against my conscience, because I think it ends a life, but it doesn't, right? And so, we sort of circumscribed conscience in that way, right? But, as I moved along, my colleague, Lisa Harris, really insisted on pulling me along in an argument that conscience is important, and it is important to respect because there's all kinds of conscientious action that shapes the behaviors of doctors, right? And so we should do our best to be able to respect that. So I think, in my mind, being sort of precise about what we're talking about when we're talking about conscience, and being clear that it's about a question of moral integrity seems, to hit a middle ground that that is better. I also think that, this is actually really one of the primary areas of struggle for physicians right now, because they really are feeling that their consciences are being broken by this current scenario. The other piece is that I'm not sure I see quite as clearly how refusal to follow the law and do something like provide an abortion that a patient needs is different than refusing to provide care in terms of impact, right? So if you refuse to provide care and somebody gets pregnant, that, maybe that is an act of not doing versus doing, but it has a very, very profound impact on a person's life, right? In the same way that the refusals to follow the law will. So I think, a reproductive health trajectory is a reproductive health trajectory. So I'm not sure that I see that distinction as clearly, but we should talk more about it. And yeah.
Unfortunately, we're at the top of the hour, so please join me in thanking